All right, like I said, tonight we're going to be covering infectious disease. Um, we've kind of been living this reality for the last couple of years, especially with COVID and respiratory diseases. But we're going to cover a little bit more than that. Some stuff I'm not going to hit on too much because it should be common knowledge, just like I kind of told you guys last week. If it's something that you are familiar with, don't take notes on it. Take notes on the stuff that you don't understand or the things that you want more clarification on. Those are the things you should be putting down for notes. Diseases, obviously, communicable diseases. This could be things such as, HIV, such as hepatitis. When I think of communicable disease, I think of, not something that can be cured within, a day or a week or something like that. It's something that's going to take a little bit longer time, especially being passed person to person. Like I mentioned, your different types of hepatitis, your HIV, AIDS, those types of diseases. A majority of those are what we're going to cover tonight. As far as agencies that mandate us as providers and how we should be protecting ourselves and who we should be referring to when maybe looking at these communicable diseases or infectious diseases, the big two for us, we have OSHA, which is the Occupational Safety and Health Administration. We should all be familiar with OSHA, right? They regulate safety, especially in the workplace. We have to wear gloves. We have to wear safety glasses. We have to wear face masks or N95 masks. And they are also the ones that mandate that we go through bloodborne pathogen training. They also help in mandating that if we get an exposure, there has to be a policy written to manage that exposure. Maybe we're being sent to the hospital to have blood drawn. Maybe we're being sent to a clinic, whatever it might be. But those policies that you have within your organization are mandated by OSHA. And then CDC, obviously the Center for Disease Control. That was something that we've dealt with the last couple of years. They are the leading agency when it comes to infectious diseases, and they put out guidelines for different diseases. Okay, one of the big things that's coming right now or that is back is the avian bird flu. So avian flu, they track those numbers, say, okay, these are the target areas where it's more prevalent. These are the areas that it's hitting the most. Here's the things that we should be watching out for. They're really the center that it takes all this information in and projects it out to the public and to us as providers. Pretty important. This can come up on your national registry, the Ryan White Care Act. This stated that any patient that you transport that has a potential disease such as like HIV, such as hepatitis, or maybe like some other disease that could be spread to you, TB, that medical facilities have to notify you about those patients. They have to notify you that you transport a patient with HIV, if maybe the patient had told you. You transport a patient that has hepatitis C. You transport a patient with TB. Early on in COVID, they were doing the same thing with COVID. We were getting a phone call or email or whatever. Hey, your agency transported this person on this date. Just so you know, they did test COVID positive that same date. You might want to just watch your people. And at that point, we were kind of keeping an eye on everybody. And some places were telling people, okay, take the next couple of days off, take a day off. If you start feeling any symptoms or anything like that, let us know. But that's through the Ryan White Care Act. That's how that the hospitals have to be able to notify us. Obviously, local departments. Here we have the Iowa Department of Public Health that is really our parent agency, oversees all of our regulations, oversees all of our guidelines, and they were really pushing agencies within the state of Iowa when it came to COVID, things we should be doing, things we should be following, as well as helping us with some guidelines, protocols, and PPE requirements when it came to that. Know the difference and write these three down. Look up the difference between them, between an endemic, epidemic, and pandemic. They're not the same thing. Epidemic and pandemic are totally different things. One could affect a specific group of people, say, like sickle cell disease with African Americans. As the word pandemic is more widespread, the COVID pandemic was more widespread, covering almost the whole globe. It has to hit a certain population or affect a certain population before they can change the classifications on it. So I would know those three things, the difference between endemic, epidemic, and pandemic. I'll tell you, when it comes to us as providers and protecting patients, I guess, from any sort of disease or anything like that. That was the big reason some services, or a lot of services, during COVID were essentially deconning their ambulance right afterwards with some sort of chemical. A big thing that was developed was using pool cleaner chlorine to disinfect the back of ambulances because COVID couldn't survive under the conditions that chlorine had. Some people were using bleach water, whatever it might be, just saline wipes to disinfect all these areas. That's something that we owe our patients, making sure that any of the equipment that we have that is going to be touching a patient is something that it has been cleaned or disinfected. Some services still carry laryngoscope blades, which they clean after each intubation instead of the disposable ones. That's fine, but they need to be sanitized in bleach and water generally before they can be reused. And that goes as part of our truck check as well, is making sure that these things are sanitized and that we don't have any issues. Critical equipment, when you think of critical equipment, think of your cardiac monitor, your pulse ox, your blood pressure cuff, those sort of things. Semi-critical, this might be something such as a glucometer because you're not using it on every single patient, but it still has the potential to be used. And then your non-critical equipment. This could be something as, something that's not packaged that you don't use very often. Like if you have any stuffed animals or something in your ambulance, those could potentially be classified as non-critical just because we don't use them very often and they're not packaged in their own package. So they still have the potential to have some sort of infection or some sort of virus they're carrying themselves. I shouldn't have to tell you guys this. Change your sheets after each patient. My service, we use disposable sheets. So after we're done, we toss them, we throw them away, making sure that the laundry is performed, that you have clean linens, or you're just taking a handful from the hospital when you go there, and then you're using some sort of disinfectant, such as like Cavicide, is a pretty common one to disinfect the back of the ambulance, disinfect the cot, disinfect the equipment that you're using. One service that I loved what they did, and Kyle, you might be able to attest to this a little bit more if you're on here. Newton, when I did ride time at Newton, they were very strict about certain days of the week they had to break down the cot, disinfect the cot. Is it still like that there?
It's true. Every week we break down everything. Every Sunday we go through all the rigs and they get broke down and everything gets wiped from bumper to bumper and disinfected.
Yeah, and to me, like at first I was like, holy cow, you have to break down everything. And then when you're cleaning it, you don't realize the amount of dirt that's on stuff under the handrails of cots, the legs of cots, places you wouldn't even really look for. And then you pull the wipe off or towel or whatever it is, and it's covered in dirt. Making sure we're checking those areas, even the side panels under our seating, in our ambulance, clean that. We should be cleaning behind the ambulance seats. These are all disgusting areas where stuff gathers. I mean, I can't tell you how many times I've looked at an ambulance and there's an old tourniquet sitting there, or maybe the packaging for an IV or something like that. That stuff should be thrown away, and we should be disinfecting our ambulance after each call. Maybe you're not doing it at the hospital. Maybe what you're doing when you get back in service. Maybe you stay out of service till it's clean. I don't know, but it needs to be done. Obviously, any spillage, what I consider spillage, think of blood. If we had a mass amount of blood that had spill on the floor or something like that, yeah, we're going to be using some sort of disinfectant to clean that up. Again, each service that comes to your local protocol, your local guidelines on how often you are cleaning these vehicles and referring to those procedures. High touch items, please, for the love of God, if you have handrails in your ambulance at the top or you have handles or something, make sure they're wiped down. Your cardiac monitor should be wiped down. Anything that is commonly touched, seat belts should be commonly wiped down. The straps you use to strap a patient in is one of the most common things that people do not clean. After each call, spray your straps and wipe them down. Not a big deal. So these diseases that can be transmitted from person to person, conditions do play a role in this. What I'll tell you, and I'm just going to talk, you guys can look at the slideshow. COVID, a big thing with COVID, and I'm going to bring that up. I don't know how many times in the slideshow because it was what we lived for the last couple of years and potentially, still living in it technically. They were saying that people weren't spreading COVID unless they had a high viral load, or that, the longer they went after testing positive, the more days, the less the viral load was. They were peaking the viral load, I think, at 2 to 3 days from exposure. So at that point, they were most contagious. They were most had the ability to be able to spread the virus, as opposed to, say they tested positive. I tested positive January 26th or something like that. I can't remember, 25th maybe, whatever date it was. And I've told you guys this before, for the 5 days that I was quarantined, every single day I took a COVID test because I wanted to see, even just on the test, I had bored. I was home, had nothing else to do. And I can watch the strip become less and less prevalent until that 5th day, it was gone. There was no positive mark on it anymore. And I kept those tests and I have pictures of them just to be able to show people the difference in viral loads. Maybe I'll show you guys the pictures or sometime soon on how that all went. But all these different potential, what do we call them, characteristics play a role in how the patient is spread. Health status of the host. Maybe it's somebody that's in really good shape, really healthy. They might not be spreading it as commonly as somebody that maybe is in poor health, coughing all the time, is a little bit harder for them to breathe just because there's certain circumstances. Direct and indirect contact. Direct contact is me coming into contact with one of you. Indirect is me touching my desk, and then you come over and touch the same desk. You didn't touch me, but you touched something that I touched. Droplet transmission, right? So we're worried about any sort of bodily fluids at that point. Airborne, coughing, COVID, or vector-borne. So any sort of, I want to call it a body, but any sort of, oh God, what's the word I'm looking for? Vehicle or whatever that this is traveling in, if you come in contact with that potentially. There's all these different ways that diseases are spread. This shouldn't be uncommon to us. Standard precautions should base off of, I take my precautions when I'm going on a call based off of what the dispatch is. Guess what? Somebody's coughing up blood. I'm probably going to wear a lot more precautionary items. I don't know if it'll change anytime soon, but I could see us wearing surgical masks on calls for a really long time. I could see us wearing safety glasses on calls for a very long time if you weren't already. And in my ambulance, whenever I work, I'd put a pair of safety glasses under the visor. Just because I've had stuff splash in my eyes before, I don't want that to happen again. Gowns are underused. Until COVID hit, we hadn't used our gowns. Even for OB situations where you're supposed to wear the gown, you weren't wearing it. And then it changed to Tyvek suits. So all these were different precautions that we were wearing to try and ward off or try to prevent infection of ourselves. A little table that breaks down what we should be wearing and what type of call we should be wearing it on, essentially, from bleeding all the way down to you giving an injection. Apparently it says you don't need gloves to give an injection. Just a heads up. Gloves should be yes on all of them. Again, a lot of this is common sense. The primary thing, and this again could be a national registry question, the most important thing is hand washing. That I can, out of every bloodborne pathogen class you'll ever take, I have to take one every year as well to keep up with my departments, my service. Soap called Hibiclens. I don't know, for some reason it kicked me out of the meeting for a second. I use a soap called Hibiclens, which is a surgical soap. It's almost a disinfectant as well, just because it's something that I'm common with. It's something I'm comfortable with, and that I don't have any issues using. It really depends on what. Some services are just using, dial soap. That's fine as long as it's a soap that has some sort of disinfectant in it. Particulate respirators. Obviously, this is something that if you're wearing a particulate respirator, maybe this is more than just an N95. We were very familiar with wearing PAPRs. Maybe you work for a fire department and you were wearing N95 filters on an SCBA mask. All this stuff was all this was stuff that we tried early on in COVID to try and prevent the transmission. Gloves, protective eyewear. Again, I'm not going to cover this. Hands, we should be washing them after we take gloves off. Needles, this is why we don't recap needles. The Needle Stick Safety and Prevention Act requires all sharps be needleless, be needle safe, or needleless systems. Sharps must be placed in a sharps container. There's a reason that sharps containers are designed the way they are. And it's so that we can't get back in there to take the needle out. Sure, can you bust the lid off it? Yeah, you absolutely can. I've had the instance where I've accidentally dropped a medication in one and had to pull the lid off just because I wasn't able to see what was going on. Or I had dropped some medication in there, was trying to get it out. Are you guys able to hear me by chance? Somebody?
Yeah.
Yep.
Okay, I had a student message me saying that he can't see my screen. Kyle, can you hear me?
I can hear you, but I can't see you. As soon as you kicked out back in again, it kicked me out.
Okay, let me.
Same here. I wonder if I need to just go
What
out
about
and come
now?
back in.
I can see him.
Is that any better?
No.
I'm still blind.
Okay, let me stop the share, and then I don't know what happened. That was odd. And I'm in my office. Can you guys see my screen now?
Yes.
Okay.
Yes.
If something happens like that, let me know. Even if I'm talking, just give me a heads up, like, hey, we can't see what's going on, or we can't hear you, or something like that. So, yeah, sharps containers. Don't want to beat a dead horse on sharps. Removing PPE, making sure that we're not touching with our bare hands. CDC guidance will say do everything possible to remove all your PPE off with your gloves on. Your gloves should be the last thing you remove, followed by hand washing. I can tell you, depending on the call that I go on, I generally wash my face afterwards as well, up to my elbows for my arms, just to make sure that I've covered all surfaces. I do work at a couple of places where I can wear EMS shorts. I've done it, and I still wear EMS shorts on some calls, but I've also been burned by it, by getting stuff on my legs that shouldn't be on my legs. So then in that case, I'm going to take a full shower when I get back. The CDC and OSHA recommend that every service get what's called a infection control officer. And this person's job is literally just monitoring, making sure that people are following OSHA guidelines as well as CDC guidelines and with your state, so our Department of Public Health, making sure that, if there's an exposure, these people are following procedure, making sure that they're wearing their PPE they should be wearing on calls, making sure that they're washing hands after every call, they're disinfecting all their equipment. That's literally the only position that this person's going to be doing. And then filling out the acquired paperwork. Maybe they're, in contact with the doctor's office regularly to make sure that if there is an instance that these people can get the help they need, whether it's a clinic or a hospital, just as far as exposure goes. If, let's say, the hospital or whatever isn't able to give you notice of a patient need transport that has a disease, Iowa Department of Public Health does act as a backup if needed, if it is a communicable disease, but they would have to be notified before that can be, that notification can be sent to us. One of the most common ones we're going to deal with, I had a needle stick early on in my career. I don't really think I've had one since. And it wasn't, the stick hadn't touched the patient. I tried to recap a needle and poke myself with it. I hadn't even used it for anything, but it's considered a needle stick. That's going to be really common in EMS. We try to prevent them as much as possible. If you have to recap a needle, put the cap on the counter, don't touch it, and then just use your other hand to guide the needle into the cap. Blood that we come in contact with, whether it be our eyes, whether it be in the open cuts, that's also a huge concern. Human bites. I don't know if I've ever had somebody try to bite me. Maybe I have. I don't know. But that's, the human mouth is probably one of the dirtiest surfaces you can come in contact with. So that makes me a little bit nervous. Blood, if they bite you hard enough, mixed with their saliva, we've got an exposure just right there alone. Things that the like the safety officer would look at is what potential for transmissible disease, were any of these actions taken? Was this COVID? How long were you with the patient? Was the ambulance vented while you were with the patient? Did you know the patient had COVID at the time? What PPE were you wearing? Those are all certain kind of things. And we've kind of done that now. I'm guessing everybody's PCR reports, it asks you COVID questions on them. I know mine does. It asks you, how many what PPE was everybody wearing? Was this a potential COVID-related call? And again, that's just for data collection, so that we, the state gets that and says, okay, out of our 3,000 COVID calls, these people were, or this many times people were missing this PPE, this many times people were missing this. So it kind of depends. If there's a potential that somebody has a communicable disease or infectious disease, obviously the services can get notified, whoever the service director is, unless you have a designated infection control officer, and then it's going to follow down the chain till you guys get notified of a potential disease. Vaccines, I shouldn't have to spend a whole lot of time on vaccines. I think we've kind of beat the dead horse with that as well. Some departments do require that people are vaccinated against certain things. Like I know my department, we do TB testing, Hep B vaccines. We have to make sure you have Hep A and that you've had all your other vaccines, such as your MMR, your chickenpox, Tdap. Usually it's supplied by the department. I know my department, we usually, like flu shots and stuff, we actually give each other the injections as far as flu shot goes, but we don't mandate the flu shot. So, but it's there for people that potentially want it. Contaminated object. Okay, I use that reusable laryngoscope blade on a patient. It's now contaminated, right? Infected would be, more of a person. Contaminated is more of an object. Infected is more of a person. You've come in contact with an organism and you now have contracted that virus, COVID. Let's use that as an example. You go on a call for a 63-year-old male, shortness of breath. You get there, gentleman's coughing everywhere. You don't suspect COVID at the time. Let's say your mask strap broke or something like that. You were exposed to it. 2 days later, you develop a temperature. Yeah, you were infected with the virus. And then carriers, people who have the disease but are not ill. This was a big concern, especially with COVID, because a lot of people were carriers. A lot of people weren't displaying symptoms. But then you'd get somebody else, a younger person that would have a really hard time with it and possibly end up intubated in the hospital with what was going on. So your patient assessment, again, take what dispatch says and build your assessment around that. It's not always correct, no, but use what they say as a guidance for what you should be wearing going on these calls. Please follow your OPQRT, your sample. I can't hit it that enough. Making sure you're doing a good assessment. The difference, again, between a paramedic and an EMT is our ability to assess patients and what we're truly looking at. It's not the skills, it's how I assess somebody. Expose the sharps properly, okay. Things that we look at for infectious diseases and how they are spread. Are they affecting a certain age group? Are they affecting a certain population? Are they more spreadable in factories? Are they more spreadable in schools? How is the disease being spread? These are all different types of things that the CDC takes into consideration when they're pulling these numbers. Say they have a large group of people that are infected. They trace this back. All these people were at church together. That's how they kind of do your contact tracing, right? Some other things they're looking at. What is the disease we're working with? Is this something we've seen before? The CDC has every single disease that's ever been fought. They have a sample of it. So all the way back to, the Black Plague or, the Spanish flu, all that. Those are things they can test against what's going on. So what happens is they take a sample of whatever you have and they test it against what they have on file already. That's how they determine if this is truly what they think it is. They can also tell your viral load based off the test. I kind of said, based off my test that I was taking, I could tell my viral load was going down because my positive strep was starting to decline. And what's the potential mode of entry? How did you potentially contract this disease? Incubation period. So when we talk about the incubation period, the time from infection to when you start to show signs and symptoms is considered your incubation period. Communicable period, when are we most at risk for sharing this disease? When are we most at risk for spreading it? And then any reservoir, how much disease do you have left over even when you're fine? When we talk about COVID, we talk about antibodies build up. They said generally you had antibody buildup for 3 to 4 months after having COVID. Okay, great, but that didn't last forever. And then how was our body naturally fighting these potential diseases? Different types of organisms. Obviously, we have bacteria, such as things that could be grown in a petri dish, things that you can culture. Salmonella is a good example. Viruses, HIV, any sort of fungus. This would be more like, I'm trying to look at the side there, athlete's foot, good example of a fungus. And then any sort of parasites. When I think of parasites, I think of, say you're in Africa, you drink some nasty, dirty water, you end up getting, excuse me, you end up getting really sick afterwards. That's because you were infected with a parasite. They bring up scabies and lice. Yeah, technically they're considered parasites as well. Sepsis, we should kind of know sepsis now. It is at the point where we develop an infection to something, right? The problem with sepsis is the really young and the really old are most at risk, the age extremes, just because they don't have those immune system buildup. The elderly, their immune system isn't what it was when they were in their 30s, and the people that are, like it says there, less than 1 year of age, don't have that immune system built up yet because they haven't been exposed to a whole lot of stuff, right? They stay inside, they stay with their parents. There's generally not a lot of sickness coming around. When kids first go to school, that's why a lot of kids get colds often, is because they're exposed to different types of illnesses. Sepsis isn't anything to play with. If you think your patient is potentially septic, we don't have a definitive way of telling, but yeah, I look if my patient's in shock or maybe trending shock, and if they've got a temperature, that should be a red flag for you right there. This patient's potentially septic. Their blood pressure is not great. Their heart rate's a little elevated. They've got a temperature. Yeah, I'm going to go with they're in some sort of septic shock. This could be due to a cut. This could be due to some sort of disease process, whatever it might be. When we start to look at sepsis, some of our signs and symptoms could be somebody with a fever, somebody that's maybe in extreme pain, shortness of breath. Look for our common signs of shock with these patients. I'm not going to cover the Q-SOFA assessment because that's done in hospital. That's nothing we do pre-hospital to assess patients that are potentially septic. Maybe you do interfacility transfers and they have you do it. That's fine. It's really just 3 components. It's your respiratory rate, GCS, and systolic blood pressure. Those are the 3 things they're looking at. To me, that doesn't necessarily tell me somebody's septic, but that's just what that score, that's what that scale is using. Management of these patients potentially obviously septic. Maybe we're looking at giving O2 if they need it. Maybe we're looking at giving IV fluids if needed, if they're potentially low. If they're consistently hypotensive, maybe we need to look at giving some sort of vasopressors. Making sure that we're constantly monitoring these patients. When I say monitoring, you should probably have them on a cardiac monitor if you think your patient is potentially septic. We're paramedics, we put people on monitors. It's just what we do. All right, getting into some of our disease processes here. Meningitis, something that I would say is pretty common. I think more people get diagnosed with meningitis than anything. It's really an inflammation of the membranes that cover the brain and spinal cord, obviously called our meninges. Bacterial meningitis is communicable. That is a communicable disease, so it can be spread pretty easily. As to where our viral isn't communicable. That's why one of the things we always want to know if we have somebody that has potential meningitis, we're looking at, or we want to find out, even afterwards with a patient follow-up, was it bacterial or was it viral? Bacterial spreads very easily, right? And does anybody remember, or has anybody known anybody that has had meningitis? What's a really common sign and symptom with that?
Stiff neck.
Stiff neck. Nuchal rigidity is the correct term for that. If you ever see the word nuchal rigidity come up, they're probably referring to meningitis. Severe headache, can't keep anything down, almost like flu-like symptoms, and stiff neck. Big signs of a meningitis. Incubation period for meningitis between 2 and 10 days. That's actually kind of a long time, right? From where they could potentially get infected to where they're showing it. Communicable period is variable depending if it is a viral or bacterial load. Absolutely, it's communicable. It might not be able to easily be spread. But I'd say with meningitis, I want to say it's 24 to 48 hours that we start to see the microorganisms disappear, as long as they're being treated with antibiotics. Within that 24 to 48 hour time frame, you start to see the side effects of meningitis kind of subside if they're being treated appropriately. Things we're looking for: sudden onset of fever, severe headache, that stiff neck, nuchal rigidity, Kernig sign and Brzezinski sign. We'll cover that more when we get to pediatrics because that kind of plays a big role in peds. Photosensitivity to light, so they don't want to see, you know, any lights. They might freak out a little bit. It might cause their headache to get worse. Dim the lights in your ambulance. Some patients could also develop a pink rash. If they have any sort of rash, stiff neck, yeah, start leaning towards meningitis. If you start, if you're concerned about meningitis at all, we should probably be wearing as much PPE as possible. We shouldn't be unfamiliar with wearing an N95. Things to ask a patient. This is really where our assessment is going to come into play. Maybe consider putting a mask on them. Again, nothing that we aren't used to. Treatment in hospital, they're looking at ciprofloxacin and rifampin. I've been on rifampin. That's the story I told you guys where all my bodily fluids were orange. Rifampin is a super, super strong antibiotic. The problem with, if I remember right, some antibiotics, anybody that's pregnant or taking birth control, it's either a special consideration or it's a contraindication to some antibiotics. I'm not 100% on that one, but I do know that pregnant patients and anybody taking birth control is a potential concern. Seasonal flu should be nothing unfamiliar with us. You know, 40,000 people a year roughly in the US alone get seasonal flu. Seems like every year I get some sort of illness around the flu time. I don't know if it's a flu. I don't know. I just manage it at home. Generally droplet transmitted, you know, because our hand to nose to mouth, because we touch everything, right? That's what these hands are for. We just touch everything and we end up spraying it all over. Incubation period's a lot less shorter than meningitis, 1 to 4 days instead of your 2 to 8. Communicable period where these people are potentially contagious. So day 1 or day before symptoms until 5 days after their onset. That's a long time that people can spread influenza. That's why they advocate for people to get the flu shot. Signs and symptoms: fever, shaking, chills, headache, muscle pain, maybe just general weakness or a malaise, maybe a loss of appetite, and then obviously some possible respiratory symptoms. I'd say duration really depends on the person. As far as testing reasons, 3 to 4 days is what they're saying. I think that's pretty common. I don't think that's anything outside of the norm or anything that's abnormal. Treatment's pretty much the same, right? Place a mask on the patient. If there's any sort of concern by you that there is some sort of something respiratory going on, put a mask on the patient. Tell them what it's for. They'll understand. They might not need IV fluids or anything like that. You might not even need an IV. Just it's patient specific. One thing to ask, especially if it's presenting like the flu, is if they got their flu shot. If they did recently, some people develop a reaction to the flu shot, so it really kind of changes. What people don't understand is the flu shot actually changes every year, the strain. They make modifications to it to include certain things, certain strains for that year that they're seeing more commonly. Pertussis, which is also called the whooping cough, caused by bacteria. So it's bacteria derivative. Incubation period 7 to 10 days, highly communicable, can be spread person to person. Most of the time, this is what we're getting our Tdaps for, right? The P in our Tdap is pertussis. Problem is with a lot of this, as far as assessment wise goes, as paramedics or anybody that works in EMS, we're not going to know that this is what the person has. I mean, you might not remember a lot of this stuff until we get done. You know, you might remember maybe tonight, but you're not going to remember a ton of this stuff because a lot of them present the same. Pertussis, the whooping cough. Patient feels like they're unable to breathe. When they finally take a big deep breath, you get like a high-pitched whoop sound. Generally, it's because they're trying to suck in as much air as possible. The problem is when they do that, they generally vomit afterwards because they have gastric upset for bringing in so much air. Again, treatment's pretty much the same. Making sure we're washing our hands, right? Pertussis is kind of phasing itself out. Maybe in population where we don't see vaccines more prevalent, but this is something we're vaccinated for at a pretty young age. Mumps. Again, this is people generally, and I'm not, I guess let me preface this by saying I'm not against anybody who's against vaccines, so please don't, if I keep preaching vaccines, I'm just following the curriculum. But generally, a lot of people that are going to contract these, which you can come in contact with, are people that have not been vaccinated or maybe didn't complete their MMR, their measles, mumps, rubella, their vaccine. Generally, they have to get 2 doses before they are resistant to mumps. Big thing with mumps is, in addition to flu-like symptoms, you're dealing with potential of glands that are swelling up. This is generally under the ears on both sides, or potentially one side. You know, you might almost below and behind the ear, and those lymph nodes right there. Those are mainly where are going to start to swell up if somebody has mumps. Problem is that doesn't necessarily mean they have mumps. I know my wife, anytime she gets sick, those lymph nodes back there behind her ears get really swollen. Your lymph system's trying to fight whatever's going on. Care for these patients, treat the patient. Treat what the patient is complaining of. Rubella falls in the same category as mumps. You know, rubella is German measles, actually. Droplet transmitted, really extended incubation period, 12 to 23 days. They're contagious up to a week before and after a rash appears, potentially. Generally, we're going to start to see this rash that will spread throughout the whole body when a patient potentially gets rubella. Additional signs, symptoms, and things we could look for, you can see them listed there. Again, we can have swollen lymph nodes. That's why they categorize this with mumps as well. Care should revolve around being supportive for your patient, treating what they're complaining of. TB is something we potentially still see. You know, if you've been to Mercy ER or whatever ER you've been to, I'm guessing they have a negative pressure room for if they have a patient that they suspect has a TB or some sort of respiratory or airborne virus. They'll put them in that room because it has ventilation, where they can suck the air out of that room instead of spreading it out throughout the other rooms. I wouldn't say it's not communicable, not highly communicable. It can be spread. It's airborne. At one point in time, this was a huge concern, especially here in the United States. 3 different types exist: typical, atypical, and extrapulmonary. Typical would be like your communicable. It's easily spread. Atypical would be not communicable, as to where extrapulmonary is not communicable at all either. So really the only one that we're concerned about is typical when it comes to spreading TB. These patients are generally going to be coughing, and that's when we're worried about the airborne virus they potentially carry. Most people you're going to see at risk, people potentially born in 3rd world countries, people in not the best living conditions. Maybe they have a poor immune system, and obviously they're not vaccinated potentially against TB. If with a TB infection, anybody who's tested positive to TB but doesn't have and doesn't develop the disease, they don't really pose a risk to anybody. TB testing, obviously, we know we get a little injection. It can be done through that lab testing, or you can get a chest X-ray done to see if the patient has developed TB. About 15 more minutes. I'll give you guys a break, I promise. Okay, let's move past TB. Biggest thing that I'll tell you with these patients is the coughing. That's our biggest concern, is bacteria that's growing in their lungs is now being exposed and expelled out into the air, and into people that, that's why it's a concern in hospitals, is because you have people that are immunocompromised, that have poor immune systems, and now we're spreading a potential virus there. That blood test or skin test that we take, quantiferin gold is what the test is called when you go to maybe your local public health, your local clinic or whatever. You guys all had to do a TB test to come to Mercy to be able to do clinicals. Generally, most healthcare facilities are going to mandate that you do get a TB test done at some point. And they're looking for to see if that lump that they inject into you, if that lump is going to stay there or not. In addition to these signs and symptoms, patients can also develop a headache, right? They can develop a fever. They can develop weight loss potentially. When it comes to National Register-wise, TB is huge when it comes to night sweats. Anytime you see night sweats, consider TB, especially National Register-wise. That is like the number one thing that they like to play on, is night sweats. Recent weight loss. It's another one as well. Really frail, thin people that having trouble sleeping at night, they're really sweaty, they can't get comfortable. We have to assume TB with those patients. Treatment, just like everything else. Place a patient on the mask, or a mask on the patient. You don't necessarily need an N95 with these patients. A surgical mask would probably be just fine. But make sure you're cleaning your vehicle afterwards, obviously. Chickenpox, technically a member of the herpes family. A concern with chickenpox is that it can develop into shingles potentially, which is really painful for some patients. Chickenpox, again, is something that is kind of phasing itself out due to vaccines, generally transmitted by, as you see there, direct contact, droplet spread, or even respiratory secretions through the air. Patients, we should all know what TB looks like. I mean, I hate to be that way, or not TB, chickenpox, is we start to get these little pock marks, right? We start to get these little red marks all around us. Highly contagious. Signs and symptoms, obviously, we're going to see these patients start to develop signs of almost sepsis. They get that slight fever. You see a change in their vital signs, the rash, sensitivity to light, and obviously general malaise and general weakness. Treatment, pretty similar to everything we've been going over. You know what? After we go over measles, I'll give you guys a break. Similar to mumps, similar to rubella. Again, remember, rubella is German measles. Highly contagious, highly spreadable disease. Some of the things we're looking for is fever, conjunctivitis. So does anybody know what conjunctivitis is by chance? Has
Like
anybody
pink
ever heard?
eye.
It's in the eye.
Yep, pink eye, right? Coryza, which is rhinitis, which is like a cold, essentially. Patient could be coughing, have that blotchy red rash to them, almost very similar to chickenpox, except you don't have those deep red pock marks as you do with chickenpox. These patients can also develop Koplik spots. What Koplik spots are these grayish spots, generally like on the inside of their lips or even on their tongue. They're almost like a white gray that you will start to see in maybe some of their mucous membranes. So when you see that Koplik spots, it's referring to measles and spots you would generally see in somebody's mouth. Some complications from measles, the patients could develop potentially pneumonia, ear infections, diarrhea, bronchitis, upper airway, really. Treatment, supportive care. I can't preach that enough. Treat what our patient is complaining of. The only certain protection against measles is immunity. Anybody who got the vaccine after a certain date, I got it, it was in the 60s, if I remember right, should be immune to the potential virus. Something we have to be screened for when we're getting hired. new place. Make sure we're washing our hands afterwards. We're cleaning our substances that or surfaces that the patients have had contact with, and getting rid of any dirty and soiled linens. All right. With that being said, let's take I'll give you guys 13 minutes. We'll come back at 7 o'clock. We're just about halfway through the slideshow, so we should be done around 8, and then I'll answer any questions you guys got. All right. So we've covered measles, covered mumps, covered rubella. So that whole MMR trifecta is gone. Next one, mono, kissing disease, what some people call it, caused by EBV, or what's known as Epstein-Barr virus, which is a derivative of herpes as well. Generally, there's no symptoms in most cases of mono. I know that sounds kind of odd. And if they are, that's just generally, no cases of Epstein, symptoms with Epstein-Barr. I apologize. Mono symptoms are generally cold-like symptoms. In addition, you might get swollen lymph nodes. You might get, maybe a sore throat. Maybe, that general malaise, maybe that shivering you could potentially see with some other common issues with people. Right, there you go. Here's your signs and symptoms. These people are generally going to be weak. It's almost going to present like, what's the word I'm looking for here? Strep throat. It'll be pretty similar to that. With mono, something we should be watching out for, though, is there is a potential for patients with mono if they're so severe enough that their temperature is spiked. Obviously, a concern for seizures. Make sure we're monitoring those as well. Big thing with mono, you don't treat it like you normally would. There's nothing too crazy. It's essentially a common cold anymore with the sore throat. Yeah, it might be a herpes derivative. That doesn't mean you have herpes then. That just means that you came down with a case of mono. Again, not very common, really. The fun diseases, as I like to call them, the ones that everybody laughs and giggles at when I usually do this class in person. So we're going to start to get into some of our sexually transmitted diseases, such as gonorrhea, caused by, guess what? The bacteria has the term gonorrhea, essentially gonorrhea in it. That's how they kind of came up with the name. Transmission occurs sexually. Generally, I know that sounds disgusting. Male or female might have some sort of pus-containing fluid. That's when we start to get the transmission of gonorrhea. Can remain spreadable if not treated. So treatment is going to not really are on our end, but in hospital, they're going to be looking at treating with, again, high dose of antibiotics. I'm trying not to laugh while I'm reading some of this. Pain on urination, yeah. With any sort of sexually transmitted disease, that's going to be one of the common signs and symptoms that you're going to see. Signs and symptoms in females, inflammation of the urethra or cervix, might even start to get pelvic inflammatory disease. Pelvic inflammatory disease we can kind of associate with a certain walk, especially when national registry test comes around. Anytime that a female is complaining of maybe abdominal pain or something like that, and they have almost like a waddle to them, we call it the PID walk. That's generally a really good sign that either we're dealing with an STD or pelvic inflammatory disease. You should be wearing gloves no matter what. Personally, I'm probably not touching any drainages or areas if I do not medically necessarily need to, or I'm going to withhold as much as I can until I have to. Syphilis, this was actually a big deal back in the day, especially for guys as well. I'm talking days of like the Old West. Syphilis was a big deal. Bacteria caused by, it is considered to be acute and can be chronic at the same time. Generally progresses in a couple different stages. So you get your localized manifestation. So you get the disease development at that point, all the way to late manifestation. God, I can't talk. Believe it or not, in the U.S. over the last couple of years, we've started to see more cases of syphilis. Transmission, again, is generally during sexual contact with its infectious fluids, or through blood transfusions. That is something as well. Blood-to-blood contact, you could potentially have somebody that develops syphilis as well. Person is considered non-contagious once they've been treated with penicillin for about 48 hours. Assessments of these patients, generally, I'm not going to know unless they specifically say that they have an STD, what we're dealing with, it's going to present very differently from anything that we deal with. As you can see there, skin rash, patchy hair loss, swollen lymph glands. Yeah, that could be a common cold. Maybe the person has alopecia. Who knows? You could potentially see cardiac complications with these patients as well, though, if it was left untreated for a certain period of time. You can also start to see central nervous system breakdown, so spinal cord, brain. You can start to see some issues with that as well. Management, treat the patients. What did they call for? Get them to the hospital. Herpes, big concern, just because people aren't, if people aren't sharing the information with herpes, then we have a little bit of a problem legal-wise, I would say, and especially we've started to see in the last couple of years. Technically, if somebody has an STD, they are supposed to notify, if they have a partner or whatever it is, they're supposed to notify them and whoever they may have had sexual contact with to let them know that they potentially have an STD. Classified into two different types. So type 1, oral secretions. Type 2 is spread through sexual contact. So type 1, when I talk about like oral secretions, generally this is brought about by stress. And it's almost, when we talk about herpes, like a cold sore, that is a good example. Blister-like sore, usually on the lips or inside the mouth. As to where herpes simplex 2, you might hear it called, or herpes simplex 1, is more of the one that we are worried about when we're talking about sexual contact. Let me change something on my screen real quick. Give me 1 second. Are you guys still able to see that?
Yeah.
It's back.
Okay. Okay. On my side, it was one of my screens. I'm using two screens. One of them was getting kind of fuzzy, so we're good now. Management of these patients. There's not a whole lot we're really going to do. There is no cure for herpes, especially, if somebody has herpes simplex 1, cold sores, they're going to get cold sores most likely for the rest of their life. Not a huge deal, not a huge concern. They can spread it to whoever else. And now I'm not saying people with cold sores have STDs. No, it's just a type of herpes. Mono is technically a type of herpes. All these different diseases are just a different classification. That doesn't mean they have an STD. I just want to get that across. Chlamydia, highest incident of all the STDs, generally through sexual contact, incubation period, for how long are they contagious is unknown at this time. In women, generally, they are asymptomatic. So they might not even know they truly have a disease until it potentially transforms into that PID that I was talking about, that pelvic inflammatory disease. Unfortunately, guys, we're the ones that get the brunt of it, especially if we've contracted it. We start to get pain, painful urination, maybe a discharge, swelling, all sorts of different things. Females generally are asymptomatic. What you're going to notice with a lot of communicable diseases or infectious diseases is that a lot of them are treated with high dose antibiotics. Rifampin, doxycycline, those are two big ones, especially just because I've been on them. I know how hard they are. Vancomycin is another big one that you're going to potentially see. Treatment, preventive measures, treated like every other EMS call. Scabies. Actually, when I was in school, when I was younger, one of the students had developed scabies. At the time, I didn't know anything about it, obviously. It's almost like lice that aren't in your hair, if that makes sense. Lice that can infect your skin, similar to that. Commonly affects whole families, children, people you have close contact with. People potentially that are in long-term care can potentially develop scabies, especially if they don't have good hygiene habits. Generally transmitted skin to skin. It is eggs, it is mites, just very similar to lice. Generally, you'll start to see a rash there of these raised red bumps, as you can see there in the picture, where a mite has essentially, I know that sounds horrible, but like buried into your skin or burrowed into the skin, which causes this intense itching pain, which is why most of the people that, they're itching at certain parts, or just like with lice, your head becomes very itchy. They start to develop sores then, open sores from the itching. Generally, scabies, just like lice, can be treated with a medicated body wash, certain lotion, treatment cream. It's considered an occupational risk, but as long as we're practicing good hygiene and we're wearing our PPE, that we shouldn't have any issues with that. Lice, again, I'm not going to hit too much on lice. We should know a lot about lice. We have eggs, we have mites, kind of similar to scabies. Signs and symptoms, you're going to start to see that severe itching, irritation, sores from them itching at it. It doesn't have to just be in your head. If somebody has armpit hair, pubic hair, whatever it might be, I pray to God there's no such thing as lice for facial hair, for mustaches or beards or anything like that. I'm sure there is, but let's hope that never come to that. Generally treated with medicated shampoo or treatment or ointment or whatever it is. Generally, it's a medicated shampoo. Depending on how severe it is, they might end up having to get an ointment cream or some type. But it's not as horrible as we thought it was when we were kids. When I thought of lice, I was terrified. Other STDs you could potentially run across: genital warts, human papillomavirus, HPV, any sort of bacterial infections, yeast infections. There's over 100 different types of HIV or HPV. Most of them are harmless to people. 30 of those 100 types are spread through sexual contact. Cancroid is essentially painful sores around the genitals. What you'll notice is that a lot of these have, again, similar signs and symptoms. Trichomoniasis, that's for us guys. I apologize, but it's almost an itching feeling inside somewhere. You really wouldn't want to feel that. In women, it's very similar as well, but you get more of a spotting factor as well as frequent urination. Skin, any sort of skin infections, right? Any sort of fungal infections. Remember, we had some bacteria there, and now we're moving into a fungi. Fungal infections, most commonly, and most of them are superficial, so no harm is done besides the skin. Generally, this is hardened skin, such as like psoriasis, or I get really bad dry skin in the wintertime, and I have to lotion my hands up something fierce just so I don't get all scaly. Like when I was a kid, my mom used to get Vaseline, and we'd get essentially gloves. She'd put Vaseline all over my hands, and I wear gloves at night just so that my skin wouldn't dry out overnight. And during the day, it actually helped me because my hands are moisturized. Generally treated with some sort of antifungal agent, some sort of topical agent, lotion, whatever it might be. Complications with these are pretty rare, to be honest. This is where we're starting to get into maybe some of our worms. Helminths is a parasite that essentially lives in human beings, contracted by touching maybe contaminated water, a contaminated animal, or guess what? Practicing poor hygiene, not washing our hands. If you ever heard like of a tapeworm, it's very similar because these parasites infect our intestines. So just a concern for us. Common side symptoms you could potentially see with that then, rapid weight loss. People are going to be very tired. They're always going to be hungry. They could be vomiting constantly. Again, are we going to necessarily treat that? No. But are we necessarily going to know? Or are we going to know what's wrong with them? No. But just some things to look out for. Bed bugs, we should all know this. It's one of my biggest fears in EMS. And I don't know how many houses I've been into that you just don't set the first out bag down when you walk in. You just hold on to it tight where it's at. Or especially if you get a phone call afterwards, hey, that patient you just brought in has bed bugs. Great. now I'm going to go burn my emails down and I'm not sleeping in my bed tonight. Bed bugs are generally found on the corner of mattresses, underneath like the lip towards the top, and like if you have like dimples in your mattress on the top, they're generally found in the deepest part of the mattress. You'll know because there's a buildup there. It almost looks like oh, what am I thinking? Like a buildup of ants, like an ant hill. You just have a bunch of them kind of compacted on top of one another. Hepatitis is very big when it comes to National Registry, so I would pay a little bit of attention to hepatitis, especially the 5 different forms we're going to talk about: A, B, C, D, and E. They all are technically potentially transmitted differently, and they could potentially show some different signs and symptoms. First one we're covering is Hep B, generally transmitted through sexual contact, potential of blood-to-blood contact, or maybe we get a needle stick, right? Hep B is the one that kind of worries me the most, I would say, just because working in EMS, if we get any sort of exposure or anything like that. A quarter of the people that develop Hep B will develop some sort of liver complications, such as cirrhosis or hardening of the liver. This is where we start to see that jaundice of patients. As you can see, they got kind of like a yellow hue to their skin. They've got the yellow around the sclera of their eyes, the white part being called the sclera. That's a huge sign. You can also see this in people that are chronic alcoholics. I'd say 50% of people that get Hep B, signs and symptoms will generally start to phase out if they're treated correctly, but it can last for a little bit of time, several weeks. If there's a potential that your patient has Hep B, they'll usually tell you. I know I've transported a couple people that Hep B. We are obviously vaccinated against Hep B. It's something we get before we get into fire and EMS, or maybe our employer verifies that we are vaccinated against Hep B, or we have to at that time. Generally, we're undergoing titer testing for that to be done. Not if you're vaccinated, the risk is very low that you're going to develop Hep B. If you're not vaccinated, the risk is still pretty low. I want to say it's like 20% that you're going to develop Hep B. Hepatitis C. This is really the most common, I'd say, bloodborne infection that we'll see. The leading cause of liver transplants in the U.S. is Hep C. So it attacks the liver primarily. As you can see, some of the things it's transmitted by, people, especially some of our chronic drug users, sharing needles or syringes, any sort of needle stick injuries, or mother to infant, unfortunately, during pregnancy, passes through that placental membrane. Roughly 10% of Hep C cases resolve on their own. That's very low. Generally, these people are going to need maybe long-term treatment because, again, it attacks the liver. Some people might not have any symptoms, but then just randomly start to jaundice after a certain period of time because their liver is starting to be attacked. How we can start to, I guess, not fight it, but prevent us is wearing our standard precautions, our gloves, our PPE that we need to. If there's potential you were exposed to Hep C, you're going to undergo testing for a little bit of a period of time. I think it's 3, 6, and 9 months, if I remember right. If found relatively quickly, you'll generally only undergo roughly 8 to 12 weeks of treatment before it resolves on its own. So if found pretty quickly before it gets to your liver, there's generally no big issues there. Hep D. Patients have to have hepatitis B first, if that makes sense. They have to be a carrier of the hepatitis B pathogen or bacteria or virus, sorry. Have to be a carrier of Hep B virus to develop Hep D. Transmitted generally through pure cutaneous exposure. So again, needle sticks. I don't know why they don't put that. I don't know why they put things in long terms. Blood to blood. Their blood is considered infected and contagious at all times. This is the one, Hep D is the one we're really worried about with needle sticks, just because it is most commonly transmitted by that. This is also a concern for law enforcement. This is a big issue within the law enforcement community, because if they're sticking their hands in somebody's pockets to search, they get a needle stick. Hep D is something that physicians have to test law enforcement for. If there was a potential needle stick, they'd test us too. But law enforcement doesn't have to follow the same guidelines as far as vaccines that we do. So their standards are a little bit different. HIV, we should be pretty common with, transmitted through sexual transmission, blood to blood contact. It's not shaking hands with somebody. It's not casual conversation. It's not touching something that somebody touched. That's a common misconception. When HIV first came about, that was the big deal with it, was, oh my God, we can't go be around these people. We can't touch anything they've touched. That's not the case at all. It's blood to blood or sexual transmission. You could drink off the same straw with somebody with HIV, and you're not gonna develop it. You're not gonna contract it. AIDS is where we start to get a little more concerned, because this is where people's immune system starts to shut down. So any infection, any sickness, anything could really start to kill these patients. That's why, treatment for HIV has come a long ways. Think of Magic Johnson and the treatment he's undergone. He lives a perfectly healthy life. Signs and symptoms of these is going to be what you think. Potential for flu-like symptoms, potential for those swollen lymph nodes that we potentially see. But the big thing is rapid recognition of this and early treatment. Generally, if somebody's going to the hospital for any sort of lab work, they get tested for HIV automatically. PPE. I can't say that enough. Please handle your needles accordingly. Don't be stupid and try recapping something that shouldn't be recapping and stabbing yourself. It's really common for HIV to, along with Hep D, to be transmitted through needle sticks. This is one of the ones, remember the Ryan White Care Act. Patient comes with HIV, you transported them. They'll generally notify you, hey, the patient was HIV positive. As well as if you get a needle stick with them, that patient now will get tested, even if they declined getting tested. They have to get tested so that you can be notified if they have it or not. One of the scares I had where I had an exposure, it was somebody that was deceased, but I had to go for testing 3, 6, and 9 months. And they also had to draw labs of the person at the morgue when they were doing the autopsy to make sure that they didn't have HIV present in their system. And I still had to undergo that prophylactic treatment just to make sure that I didn't develop anything. Ebola, direct contact, droplets, healthcare workers kind of been dealing with this for a while, 4 years roughly. Ebola is pretty much limited to West Africa for most of our outbreaks, so it's not really a pandemic at that point. We thought Ebola was going to come here for a while. That's what some services freaked out about. They had these UV lights. They had these little helmet things we would wear that kind of blew air in front of our face, so there was no potential for Ebola coming here. Ebola is nasty stuff, but again, it's more of our third world countries that we're going to potentially see. It's nothing that's super concerning here unless the CDC starts to put out information on it. But if you have a patient that's traveled to, let's say, West Africa or a third world country, and they now have a fever, muscle pain, sore throat, yeah, that's obviously a concern. Do we know it's Ebola? No, but they came from a different country, and now they're showing some sort of signs and symptoms. Ebola also, these patients are potentially going to go into hypovolemic shock due to their constant diarrhea, vomiting. They also could experience internal and external bleeding, just because as they're vomiting, that's very acidic. Over a long period of time, it starts to break down the walls of your esophagus, your stomach, whatever it might be. Treatment for us, supportive care, making sure we're wearing the right PPE. Again, we didn't know a whole lot about Ebola in the beginning. We know a little bit now, but again, most outbreaks are isolated to West Africa. If you have to put the patient's belongings in anything, put it in a biohazard bag, as well as if they're going to vomit, because it is considered biohazard at that point. If you suspect a patient of having not just Ebola, any communicable disease, make sure you're notifying the receiving facility so they can have a room ready that potentially is negative pressure. Maybe they need to decon somebody, whatever their protocol are going to be. Just make sure you're giving them a somewhat of an advance notice. Norovirus. I'm going to kind of jump through this one because there's not a whole lot of stuff on it. Hep A. This is one that we had not covered yet. Hep A is more, it's more of your infectious, I guess you could say. It's actually one of the names for it is infectious hepatitis, because it is one that is transmitted most often. I know it sounds disgusting, but a fecal oral route, it's because people don't wash their hands is what it is. And it's one of the ones that we have a problem here with it in the United States. It can be caused by certain food products such as milk, certain meats, certain undercooked fish, certain water that maybe hasn't been filtered. You can develop Hep A from it. Once you have Hep A and say it's treated or whatever, you have a lifelong immunity to it though. So you can never develop Hep A again. Different phases. Obviously, your phase one is going to be your early phase, where the patient essentially starts to develop their first symptoms. Again, flu-like symptoms. As to where your phase 2 is more going to be your later signs and symptoms. You know, the patient's starting to jaundice. They have dark colored urine because their kidneys are kind of getting worked on as well. Pale colored stool. I should have taken all the management slides out of here because they're all the exact same. Generally, us in healthcare, we are vaccinated against Hep A as well. Does a vaccine give us 100% certainty we're not going to contract something? No, it does not. Hep E, again, fecal oral route, potentially contaminated water as well. Again, third world countries. Generally, this is going to be developed by somebody that's traveling in from out of the country, maybe from a third world country. This lasts a little bit longer. This was a huge concern for a while. If you remember West Nile disease and all these sort of bug transmitted diseases that we had to deal with, zoonotic diseases, if you will. West Nile, Zika was another thing as well. Some tick-borne diseases, you know, Lyme disease, Rocky Mountain spotted fever. Those things, these are all things that could potentially be on your national registry, right? I can tell you right now, I would spend some time looking at Rocky Mountain spotted fever, looking at West Nile, looking at Lyme disease. For some reason, the National Registry likes to hit on these bug-driven diseases. West Nile started in Africa a long time ago, 1940s maybe. Hit the U.S. around 2000, if I remember right. Generally, the scary part was it was being transmitted through mosquitoes. Mosquito would essentially bite somebody that was carrying or that was sick, that would infect the mosquito with this virus. That virus could then be transmitted essentially wherever, just because it was airborne in a bug at that point in time. Most people with West Nile don't know they have it. As you can see there, 20 to 30% are symptomatic. 70 to 80 don't even know they have West Nile at that point. Again, how do you determine it's West Nile versus the flu? You look at if they've traveled or not. You look at any recent bites they potentially have. You know, have you been bitten by anything recently that you know of? Well, I have this mosquito bite I keep itching at. That's a red flag. That's a smoking gun, what I call with my patients. Zika kind of came about, I'd say, for some reason, I don't know, 3-4 years ago, Zika was a big thing again. It wasn't, I'd say right before COVID, it wasn't like it was spreading like wildfire, but there were patients, certain children developing cases of Zika. All the cases that had originated in the US came from somewhere else. We have not had a case of Zika develop in the U.S. It was people traveling from outside into the U.S. that had acquired it from outside. Transmission from a mother to a child is pretty common. That's where we were starting to see those Zika infants, if you will. Really, you could really tell they had Zika because they had really small heads. I hate to be that way, but it kind of looked like if anybody's ever seen Beetlejuice when his head shrinks in the clinic. It was very similar to that. They had what's called microcephaly, which is a smaller head or smaller brain as well. Can be transmitted sexually from an infected male to his sexual partners. It's been documented. I don't know to what prevalence it's been documented. There is a correlation between Zika and Guillain-Barré syndrome. If you don't know what Guillain-Barré syndrome is, it's essentially progressive weakening that leads to paralysis. You know, if you have a patient that maybe wakes up one time and they just can't move their legs, they're paralyzed, they could have developed Guillain-Barré due to an infection, due to a vaccine, whatever it might be. Guillain-Barré can cause paralysis for an unknown period of time. Some people it will resolve in, and some people will be paralyzed for a long period of time. Zika virus is present in all bodily fluids. Again, with a lot of these diseases, have they traveled from Africa? Have they traveled from a third world country? If somebody has a fever, that, you know, we were asking it during COVID. Have you traveled from China? Have you traveled from anywhere outside the US? Those aren't normal questions we would normally ask somebody. It's okay to ask them. If they tell you the truth, great. If they don't, it didn't hurt to ask. Lyme disease, most common tick-borne. This is actually an issue in the Midwest, is Lyme disease. You'll also start to see it along the coasts, Atlantic and the Pacific as well. Generally in between your June and August season, when it's a little bit warmer out with the potential for ticks, you know, heavily wooded areas, woods, wherever you're at, areas with heavy timber. Lyme disease will present as a red target. You can see almost in the middle, it's whitish to the color. It literally looks like a target, like you're gonna throw darts at it. Problem with Lyme disease is it affects more than just the skin. It can affect your heart, joints, your nervous system will start to break down. People with Lyme disease that don't seek treatment right away can end up in the hospital for quite a period of time. Early stages are when they start to develop that rash. You know, they see that bullseye rash, they should probably be going to the hospital to get treated. You know, they let the disease progress even further, and that's when they're going to start to see, you know, almost TB-like symptoms. Their lymph nodes are going to start to swell. They're going to have this non-productive cough. They're going to have a sore throat. Anything left untreated will start to hurt somebody. If left untreated long enough, they can develop muscle problems. They can develop joint problems, almost like arthritis, where they start to develop joint pain. Severe fatigue, could be like in a really bad mood. I can't tell you the person last time I was bit by a tick. I don't know why I haven't been, but it was one of those things as a kid where I grew up. We commonly, if we came in from outside, we had to search and look and make sure we didn't bring ticks inside. Check your hair, check behind your ears. I mean, anywhere you're checking to see if you've been bitten by a tick.
The Lyme disease one's actually a deer tick. It's a smaller one.
What was that?
It's a deer tick. It's not the regular ticks.
Correct. So the size of the tick is different. But here's the thing: is people generally aren't going to know that. You know what I mean? Is people aren't going to know. Okay, you know, I don't know the normal size of a tick. Personally, I don't. So if I got bit by one, to me, I'm going to say, yeah, I know it's a tick, but I don't know what the size is. Now, if they start to develop any signs and symptoms and they start to develop that rash, and I ask, hey, you know, they tell me, yeah, you know, I got bit by something. What were you bit by? Well, a tick. That should tell us right there in our assessment what we're potentially thinking of. Has anybody ever had Lyme disease? I'm not like trying to be pushy or anything. I know a couple people that have actually had Lyme disease before being bit by a tick. One of them was actually hospitalized for a certain period of time just because they didn't want to believe that they actually had it. Rocky Mountain spotted fever, again, transmitted through tick bite. This is 3 specific ticks. You have the Rocky Mountain tick, you have the American dog tick, and you have the brown dog tick. So when you think of any sort of dog tick, you're probably looking at Rocky Mountain spotted fever. Problem with Rocky Mountain spotted fever is that it can be fatal if left untreated. And when I say left untreated, like it needs to be identified pretty quickly within the first 3 days, roughly, or the person could develop fatal symptoms. The problem is all these symptoms mimic a flu. Unless they specifically know that they've been bit by a tick, we might not truly assess this correctly and consider what we think is going on. Doxycycline is first-line treatment. I told you guys my story about how I had some sort of infectious disease and I was in the hospital. The 2 drugs they treated me with were rifampin and doxycycline. I think it's because they weren't sure of what I had at the time, and so they were throwing very strong antibiotics at me to see if my body responded to it. Hantavirus, otherwise known as hemorrhagic fever, generally associated with mice. To be honest, areas that are infested with mice, patient will start to develop almost like flu-like symptoms. Any sort of rodent, it could be like the shreddings they live in, feces, saliva, a rodent bite. Where we always get concerned with the hantavirus. Early on when people were coming here in ships, the hantavirus is a big issue because we had these ships that were essentially rat infested, weren't the cleanest areas, and we were, bringing these people from a third world country into the U.S. and they were bringing over different types of viruses and different types of infections. Sudden onset of fever, headache. Again, I call those flu-like symptoms. When I see fever, headache, loss of appetite, pain, vomiting, to me, those are flu-like symptoms. The first phase that we're going to potentially see with these patients is the fever, chills, again, flu-like symptoms, maybe abdominal pain. Second stage is going to be any sort of coughing or more progressive pulmonary symptoms. Maybe this person's now developed fluid in their lungs. They have some sort of edema. Maybe they have low blood pressure because of the pressure on their chest. Maybe their heart isn't pumping like it should. Stage 1 is common signs and symptoms. Stage 2 is where we start to progress to something that's a little more severe. Treat the patient. They need oxygen, put them on oxygen. If they need intubate them. Treat the patient, not the monitor. All right, let's do this. Let's take a 6-minute break. That'll put us out at 7:44. And when we come back, we have less than 30 slides left, and we'll get through these pretty quickly. So take a 6 minutes, 7:40. Let's just do 7:45. Come back and we'll finish out the slideshow. All right. Like I said, we don't have many slides to go. Rabies really started to decline in the U.S. I'd say over the last 20 years when we started to really track it, when different control programs began, such as vaccinating and making sure dogs are vaccinated against rabies. Transmission is directly related to the bite of an animal, generally raccoons, skunks, foxes, coyotes, even some types of bats. When you think rabies, you think dog for some reason, but that's generally because the dog was bit by one of those animals that had gotten a fight with another one of those animals and had developed the rabies. It can potentially be transmitted as well through eyes and mouth. Pretty uncommon for that to happen. If somebody develops rabies, maybe they've been bit by a dog that had rabies or something like that, human contact is not, there's been no cases of anybody spreading rabies from human to human. Obviously, I call them phase one. Some of the things we're going to look for, again, our flu-like symptoms, our fever, our shakiness, our weakness. Also throw in paresthesia there. So that generally, paresthesia is going to start near the injury site and work its way out. And then we'll start to see, if left untreated, the potential seizures, the bizarre behavior of the patients because our central nervous system is affected. Hydrophobia. I'm not exactly sure what hydrophobia is. I'm not going to lie to you. But you'll start to see mental status deteriorate if left untreated with these patients. If somebody's potentially bitten, potentially by an animal that has it, they need to go to the hospital. I don't know what else to say to that. There is no vaccine for us to be vaccinated, or there is, but it's not generally recommended unless you're going to be working around animals or something like that to get vaccinated against rabies. MERS, Middle East Respiratory Syndrome, MERS-CoV might sound a little more familiar. Was a viral disease that presented actually a really small risk to us as EMS providers. Really the general public in the U.S., I would say in general. Transmission generally occurred close contact from one person to another. Person had to be infected with a pretty high viral load before they could really infect another patient with MERS. Again, we're looking at travel history. Where do these patients travel from? Egypt, Iraq, Afghanistan, wherever it might be, Middle East. That's when we start to get a little bit concerned, especially if they're starting to develop some signs and symptoms such as, fever, cough, shortness of breath. Those are always concerns when somebody's coming from out of the country, as well as potential, for our nausea, vomiting, GI disturbances such as diarrhea, maybe vomiting up blood potentially. This is a respiratory illness, so we might have to do some respiratory stuff. We might have to intubate these people if it comes to that. Truly, base it off your patient assessment. How are you going to treat these patients? No treatment really exists for MERS. Basically, treatment was revolving around the symptoms. How do we treat the symptoms? If we can treat the symptoms, we can take a lot of pressure off the body. But as far as treating it itself, no, there wasn't. We were just treating symptoms with MERS. Tetanus, again, something we get. Tetanus shot, it's included in your Tdap. More common in areas where people are generally working around metals. They have a higher incidence of potentially getting stabbed with something metal or metal's fragment essentially being embedded in them. It is vaccine preventable. Generally, if you get an injury that has metal or something like that and you have your tetanus shot, you will generally get another one at that point, just to be prophylactic about it. And to, I think they're generally good for, 5 years, 5 to 10 years, if I'm not mistaken. But what our big concern is with metal is obviously, what has that metal been touching? Soil, feces, rust is always a big concern when there's metal. One of the big signs of tetanus is you're going to potentially see lockjaw with these patients. You're going to see muscle contractions, almost seizure-like activity, really mainly in the face and abdomen, face and trunk. So face, chest, abdomen. Generally not in your extremities. Some of the other signs, symptoms, it'll honestly present very much like a stroke. Dysphagia, so difficulty speaking, drooling, respiratory distress. Those are all things that potentially somebody we could see having a CVA or a stroke. treat your patient based off what they're presenting like. If they need oxygen, IV fluids. If they're in shock, you know, again, like I said, for us, I'm pretty sure recommended is every 10 years for a tetanus shot. But if you get an injury, they're probably going to give you one sooner than that. You know, I'd stepped on a metal rake at one time. I think my tetanus shot was 5 years old at the time. Guess what? I got another tetanus shot. They cleaned out the wound. No big deal. You've got your shot, your vaccine. We'll give you another one just in case. Infection with antibiotic-resistant organisms. This is a problem because how we're used to treating them is no longer working. Because these patients, over a period of time, the disease has evolved. It's learned that, okay, we treat it this way, so it's going to become resistant to that. That's an issue. It's why some hospitals and medical facilities, you know, back in the day, we used to treat everybody with antibiotics for everything. The problem is that we were giving the body, it was building up resistance to these antibiotics. So that when it truly needed it, the antibiotics wasn't working. So a lot of places have limited what we treat antibiotics with just for that aspect. Penicillin, methicillin, some of the ones that obviously became resistant early on, starting, I want to say, in the 70s. This is where we really start to see MRSA, the methicillin-resistant Staphylococcus aureus. Easy way, let's call it MRSA. The only known thing to treat MRSA they're going to treat it with right off the bat is vancomycin. Vanc, you might hear it referred to. It's a very strong antibiotics. Some strains will still show resistance, but you know, if you ever transport a patient with MRSA, you get a little bit concerned because you're not sure. You know, God, I don't want to be transmitted to me. Generally, it's carried in their mucous membranes. Most of the time, we're going to see MRSA in people that have had a prolonged hospital stay. Maybe they've been in the ICU for a long period of time. Maybe they've been in a burn unit for a long period of time. Or even a nursing home or long extended care sort of facility. Or maybe they've been on antibiotics for a long period of time. That's where we're really going to start to see this MRSA develop. Some of the signs and symptoms, as you saw in that previous slide there, localized abscess. They could potentially have cardiac problems, but it's not very prevalent. Blood-to-blood contact, obviously, we want to prevent. Any sort of infection that is presenting as such as a, what am I thinking here? Like a boil or infected, almost like a large pimple, abscess. They're going to go in and incite that wound and drain it. They're not going to put them on antibiotics at the time because the antibiotics isn't doing anything. The only time they're truly going to treat these people with vancomycin is when they're in the hospital for a stay. And they might even prophylactically treat somebody that could potentially develop MRSA with vancomycin. MRSA, we also have VRSA. VRSA more presents with skin conditions, pimples, boils. The problem is if those pop or if they leak anything, those are potentially infectious. It's super rare, especially in the U.S. There's really not any documented cases in any time lately of a case of MRSA. What we see most of the time is our cases with MRSA, and again, that's patients that we've seen long periods of time. Recent hospitalizations, recent exposure to long-term antibiotics, and I don't care vancomycin or not. Long-term antibiotics, whatever it is not good for a patient. Signs and symptoms, obviously, in addition to these four, you can also see, you know, fever, chills. Patients can develop pneumonia as well, chest pain, maybe some trouble breathing. It is treatable with antibiotics. The problem is antibiotics also hurts it, or not hurts it, but hurts the body. So they've got to be careful on what type of antibiotics they're putting these patients on, especially when we're talking any sort of antibiotic-resistant virus or bacterium. Vancomycin-resistant enterococci, it's pretty much the same thing. The only difference is that's mainly affects the GI tract. So you're starting to see those patients develop vomiting, diarrhea, not super transmittable, but can be transmitted person to person. C. diff. This is a big one for us in EMS. This is after long-term antibiotic use. Patients can develop C. diff, which is a bacteria that develops in their intestines due to prolonged diarrhea, because the antibiotics causes bowel movements, especially ones that aren't completely solid. So what happens is their intestines start to become injured, or they start to develop this bacteria due to that almost watery stool-like substance. If you've transported somebody with C. diff, you know what I'm talking about, the smell that you can smell right off the bat to tell if somebody's had C. diff or if they have C. diff. It's a pungent, sour-like smell. I get sick thinking about it. Signs and symptoms: frequent watery green, foul-smelling diarrhea. Again, that's generally caused by the long-term antibiotics. Nausea, vomiting. They're really going to show GI symptoms. Problem is with C. diff, if left untreated, patients can become super septic, and they can also, another concern is a perfed bowel, any sort of tear in the lining of the intestines or even in the colon, just because of that long-term acidic, diarrhea that's been going through just because of this prolonged antibiotic use. Gloves, hand washing tech, please just wear your PPE like you're supposed to. SARS, severe acute respiratory distress syndrome. This is where we start to get into like bird flu. This is really transmitted from animals. Believe it or not, it actually started with a bat. I know that kind of sounds familiar, because COVID was SARS-CoV-2. That was its name for it. So it was a derivative of SARS. And when we start to get into signs and symptoms here, they're very similar to what we were used to dealing with the last couple of years. COVID was a derivative of SARS. Fever, headache, general malaise, weakness, body aches, dry cough. Sounds very similar, right, to what we had been dealing with. Recommended PPE for these patients is an N95 or a respirator. Again, generally, patients had to undergo a 10-day quarantine. Makes sense. Here's our bird flu. Again, if you look at the news, it's kind of, and actually there's a couple facilities here in the Midwest, in Iowa specifically, that they've had an outbreak of bird flu. Symptoms, again, flu-like symptoms, that fever, sore throat, cough. Follow your PPE, put a mask on your patient. I don't know why it boggles me. Even now, we transport somebody that potentially has COVID, put a mask on them. It's not going to kill you. Obviously, if they have trouble breathing, maybe don't put a mask on them. But anything else, we should be putting a mask on our patients. All right. Like I said, that was the last of the long chapters for the rest of the semester. The rest of the nights are super easy, super laid back. Some nights we're doing 2 slideshows, and it's not going to take us forever. I do have to finish making your test for this chapter and your last chapter. I'm not going to put anything on there we haven't covered. Use your book. Use your book to take a test. I give you guys that option. You'd probably do it anyway, even if I didn't. That's why I do it. Use the resources that are available to you. We record these lectures. I post them right after every single time. As soon as it's downloaded, I post it to D2L for you guys to review. There's no reason you guys don't have every resource you need to help you get through these tests or even study in that matter. Are there any questions I can? Oh, go ahead.
Yep. So the slides that you went through tonight,
Yep.
so a lot of the titles were not there. So I'm just wondering, when we go back over, is that information going to be there?
Yeah, and I'm going to upload this PowerPoint to D2L.
Okay, good deal. Thanks.
Hey, Rudy, I just want to say a couple things real quick here.
Yeah, go for it.
Okay. So when I was living in Wisconsin, back in 2010, we actually had a rabies outbreak from a little girl that got bit by a bat on a school trip. So your hydrophobic thing is the fear of water. That's when they get to the point where they're ready, when they get afraid of water to drink, because it actually hurts them to drink it.
Sure.
It causes.
I guess that makes sense. Hydrophobia.
So I actually, was really enthused with this case because she was like a 17-year-old girl and she actually made a full recovery, but she was in the hospital for like 3 months.
Oh, wow.
Yeah, it was actually a
Um,
big deal.
How did she develop it? What did you say? I
She
missed
was
that
on a
part.
field trip and she found a bat
Oh,
and she picked it up and
okay.
got bit. But they didn't realize it till later on after they talked to the little girl back after she came out of her coma and everything else. But she was like 3 months in a coma and just really got off and made a wonderful recovery.
Mm-hmm.
I was intrigued with this actually a really interesting case.
Yeah, sure.
And your other thing about mono, I
Mhm.
found this out the hard way. My son had mono, and if you give them penicillin, because they treated for strep throat, they'll develop a rash.
Yep.
So I thought it was kind of cool too. So,
Yeah, and that's depending on some medications and a lot of antibiotics too. Like my brother, anytime he takes it, he's not allergic to anything, but he develops a rash anytime he's on any sort of antibiotics. So and that's the bad part with infectious diseases is you're literally throwing medications at it, seeing what it's going to respond to. And that's why some diseases such as MRSA and VRSA came about, is because we were throwing too much antibiotics at these patients and their bodies became resistant to it. And it's not essentially the virus is resistant to it. It's that your body isn't using the antibiotics like it should, because we were using it for everything.
yeah, I just wanted to throw that out there because I thought it was kind of cool.
Yeah, sure. Thank you. Anything else for the good of class? I just uploaded this PowerPoint to D2L, and as well as the other, your guys' book PowerPoint is on there as well. They both do contain the same things, so there wasn't anything I failed to cover. You can look them over. I also did put the chapter 10 handout on there if you want to follow through with your book, maybe just to help you study a little bit, use that. Other than that, there's nothing too crazy. Like I said, some of the chapters coming up, super laid back, super easy. Maybe something you don't take a lot of notes on. Maybe you spend some of the time reviewing some of the stuff that's harder. By all means, go for it. I'll send you guys an email when that exam is open. Again, I've got it between today and tomorrow. I'll get it finished and post it up on there for you. And if you have any questions, please, obviously reach out to me. I haven't had access to my email for the last 3 days because I'd left my computer at work. I've been trying to access it from my work computer. If you send me an email and I didn't respond in timely fashion, that was the reason, and I apologize about that. But are there any questions I can answer for anybody? Anything at all? All right. Well, you guys have a great rest of your night. If you have any questions, please, as always, send me an email, send me whatever.